Right, so a few things, thank you. So I'm Greg, I think most of you know who I am. You'll have to put without me dodgy wallpaper today. We've got 45 minutes, so I'm gonna get through as many questions as possible. I think Emma Taylor, Emma is on the line, so Emma's gonna try and manage that as best she can. If I don't intend to do loads of talking up front, but if I do a sort of a 5-minute, where are we now? What does the situation look like today? And then you can take some go anywhere you want from there, within limits. Only thing I'll say is I'll try and be as up to date as I can, but I've been in the office all morning and I've not been looking at the news, so I don't know what's happened today. They all may have changed. So if I do about 5 minutes on where we are, I'm just going to screen share 1 or 2 slides. Some of you may have seen some of these before. Screen share, hold on. And then I will, right, about 4 slides. Yes, Emma, you can have permission to record, or Ben, you can have permission to record, that's fine. 4 or 5 slides. Whole country is hotting up quite quickly. This is a week or so out of date now, but this is the sort of the look and feel of the epidemiology nationally. The geographically challenged of you can see Sheffield is about thereabouts. We're now on week 41. Of note, the slide I haven't had time to update yet, but the colour scheme has changed to make it look like there's less red. But in short, the key metric, 7-day incidence per 100,000, is going up across the country and going up quite quickly. The northern university towns, particularly the northern university towns, but also the southern towns as well, is going up much more quickly. So, you'll have seen that elsewhere. So that's one picture that gives you a sense of the epidemiology across the whole country. This is now a month or so old. Numbers were quite low, fluctuating. This is a week old. Numbers were in the order of 350 per 100,000, probably a bit lower than that, so probably about 300 per 100,000. Almost all of the rise over the past month or so has been in the 18 to 25-year-old age cohort. And of note, we've just welcomed tens of thousands of 18 to 25s back to the city because it's a big university town. So that explains the rise. No doubt about that in my mind, that explains the rise. There's some caveats which I'll come on to in just a sec. The rate as of today is in the order of 450, 460 per 100,000, there or thereabouts. Still principally in the 18 to 25-year-old group. That's beginning to stabilize. The graph doesn't show the stabilization, but I'm just seeing some signs of stabilization in the university population over the last couple of days. And that's a trend that's been reported more definitively from the Scottish universities that were started two, three weeks before the English universities. Students came back, freshers do what freshers do, big outbreak, then stabilised. And there's signs that's beginning to happen in Leeds, Sheffield, Newcastle universities. It's a bit early to call it definitively, to be honest. Most of the epidemiology, most of the rise is in the 15 to 34 bracket. Ignore the slight tail off, that's just to do with data not being complete. So most of the rise is there. However, and the green line is the one that causes me most concern. There is a rise in the 7-day rate per 100,000 in the over 65s. So currently we're on about 160 per 100,000 there or thereabouts in that age cohort. It's water, not Diet Coke, before any of you ask. There has been Diet Coke in there. Concerns, epidemiology. Doubling time is about every 7 to 10 days, there or thereabouts. That's quite stable, but that's quite a quick doubling time. What we've seen in Liverpool, Merseyside, hasn't yet happened here with regard to hospital activity, but hospitals are beginning to be quite busy in Sheffield and South Yorkshire. Not insignificant number of new admissions with where people test positive for COVID every day. Of note, and there's an important caveat on that one, there are many people who are being admitted to hospital and then are being tested for COVID and testing positive. So what, I'm to overcharacterize, I'm admitted because I've had a heart attack, I'm correctly tested because the hospital are testing all patients, and I'm then found to have COVID. So it's picking up essentially asymptomatic COVID. However, there are a significant number of people who are on oxygenated or ventilated beds, and that's beginning to creep up. So way off capacity, but the shape of the curve is pretty clear. So it's a big concern. What I'm seeing is a ginormous outbreak in 18 to 30, mainly 18 to 25-year-olds. I'm beginning to see that stack into older age groups. The graph begins to explain that. So that's basically the epi-summary of the last couple of weeks. Sustained and fairly rapid rise, diffuse across the city, mainly household clusters. I'm not seeing a huge amount of big outbreaks associated with certain settings. Arnold's definitely above 1. This is an incredibly infectious disease, and Arnold's definitely above 1. We don't calculate it at city level, but it's definitely above 1. I've no doubts about that. Ethnicity substantially shifted. A couple of months ago, it was principally amongst the South Asian population. That is not now the case. It's diffuse across the whole city. Not quite, but largely reflects the city ethnicity makeup. Mean age of a case is really low, driven by a ginormous outbreak in younger people, and probably reduced exposure in older people who are protecting themselves. And the trend at the moment is on the back of young people returning to young people behaviours. A few weeks ago, it's returned from holiday. At the moment, it's welcoming students back to Sheffield. There have been student house parties. The two VCs are pretty clear that not much of that anymore, but there will be some, no doubts about that, but no single cause. So that's about all I'll say on EPI, and I'll pick up questions later. Next thing I'll talk about is briefly the COVID alert levels, or level 1, level 2, level 3, now renamed medium risk, high risk, and very high risk. You'll all have clocked that Sheffield, Boris Johnson announced last night that Sheffield and actually South Yorkshire is in the high alert level, essentially the medium category. That is in effect from tomorrow. I think regulation's been laid in Parliament today. I think it comes into law tomorrow. You'll have read the what you can and can't do yourself. I won't dwell on every single line, but essentially more restrictions with regard to household mixing. People must not socialise with anybody outside their household or support bubble in any indoor setting, whether at home, in public place. That does affect the hospitality industry, make no bones about that. People must not socialise in groups of more than 6, including garden or other spaces. Businesses and venues should continue to operate within a COVID secure manner. That's taken as read. Curfew still applies. Universities, places of worship, schools remain open. Weddings and funerals can go ahead, but with restrictions on number of attendees. That's largely akin to now. Exercise classes and organised sport can continue to take place outdoors. They will only be permitted indoors if you can avoid mixing with people you don't normally mix with, and people can continue to travel to venues and amenities which are open for work, to access education, but limit journeys, and then there's a whole bunch of other stuff. So there is no clearly defined threshold for intensification of that to shift to the very high level. My sense is it will come. The numbers are going upwards, and my sense is that will come. Difficult to call when, where, and how, to be honest. There are a million nuances and discrepancies about I mean, this category and that category, can I do this, can I do that? And I can't answer all of those. It's impossible for me to answer. And there are discrepancies in the guidance. No doubt about the fact there are discrepancies in the guidance. My approach from the outset has been to kind of boil it back to the basics. And the basics, I know many of you have heard me say this: wash your hands, keep your distance, wear a face covering. Social mixing and household transmission is the business end of this. There's no doubt about that. We know that from our epidemiology. You could interpret the rule of 6 to say, I can have 5 people in my house today. Well, up until tomorrow, you can. 5 people in my house today, 5 different people tomorrow, 5 different people the day after that. That's 15 people. That's 15 more opportunities to meet. So for me, my sort of rule of 6 is get a social circle and keep to it. we as a city, we've continually said we're trying to focus on clarification of the core messages. I come back to that time and time again. Consensus and consent. It will be difficult to enforce our way through this as a city. I think we will end up erring towards level 3, i.e. the more restrictive. It's definitely all about social mixing, and no doubts about that. That's the push from the government. Education is definitely off limits. Prime Minister's made that very, very clear abundantly on a number of occasions. I think work is off limits, notwithstanding the work from home where you can. Lots of us can. I happen to be in the office today, but I've been at home most of the time. But there are lots of people who can't. And that leaves other social mixing, so household leisure, etc. That may come to Sheffield. I don't know when, where, and how, but that may come. I'm really clear. The pubs, in particular, the leisure industry has done a huge amount to make itself COVID secure. No doubts about that. There has been some spread in pubs and clubs and other places, but not loads. But there has been some. I'm not convinced on the circuit breaker type of mentality, you know, short, sharp shock. For one reason and one reason alone, it would need to be a really long circuit breaker, given the rate of increase is quite rapid, but the rate of decline is actually quite slow. To substantively make a difference, the circuit breaker will be very long. So for me, the other thing that's worth me noting is that the economic support package has got to be really, really clear. So our strategy throughout has been protect the vulnerable, keep people, actually no, in this order, keep people safe, which is about reducing spread, protect the vulnerable, which is about those who are particularly vulnerable to severe disease, get the economy going, and follow government advice. So the economy and we all know there are economic and social impact of measures to control spread. So the economic support package for whatever restrictions are imposed needs to be really clear for businesses, for individuals, both individuals who may not be able to work because of isolation, or individuals that may not be able to work because of restrictions on the business and the ability of the business to operate. That's got to be abundantly clear. It's becoming clearer, actually, to be fair. I'm hoping you're not going to ask me loads of detailed questions about the economic support package, because I know about epidemiology of infectious diseases. I'm not an economist, so go gentle on me if you're going to ask me loads of those questions. The last few things I'll say, the exit strategy needs to be absolutely clear. Once we're in, I think we're in. This will be a long, difficult autumn and winter. Of that, I have no doubt. And government haven't yet been clear on what the exit strategy is, and whether or not it's owned by local areas, or whether it's owned by government, or whether it's a shared endeavour. That needs a bit of clarification. This is happening now, this week, really quite quickly. I have some suggestions, and I've made those to government, but my suggestions would be about incidence of cases per 100,000 in the over 65 age group. That's the group of the population most at risk. Test and trace and isolate working, coverage and speed, and our ability to manage incidents, of which there are many in Sheffield. So I've said that. I mean, the basic strategy, I think, is intact. We come back time and time again to the basics. The basics at individual level, you've heard me say it before, I'll say it again: wash your hands, wear a face cover and keep your distance. Limit your social contacts. The more social contacts you have, the more opportunity there is for a virus to spread. The end. It's really as simple as that, to spread and accelerate into new groups. And then there are basics at city level, which we need to be sorted, which are about rapid test results. So if I have symptoms, even if mild, our encouragement is to get a test. The result needs to be quick. That is beyond my control. It's not my testing program. It's the Department of Health and Social Care testing program, but it needs to be tested, and rapid and complete contact tracing. We have stood up and are beginning to operationalise a local contact tracing system, works with NHS Test and Trace, not separately to it. but it's not resourced by NHS Test and Trace to the level we need it to really get to where we need, which is shifting from somewhere in the order of 73% completeness to somewhere in the order of 95% completeness, which would be the ideal. Would never get to 100%. And then the last thing, which definitely is beyond our control, but we're working pretty hard on, is the economic support package to individuals and businesses, because we're all really clear that we need to minimise the economic harm that comes from measures to control a very transmissible, very infectious and really rather dangerous respiratory disease. So we're sticking to our path of the middle ground. Before someone asked me what my views on the herd immunity strategy are, I'll tell you now, it's a crazy idea. It's absolutely crazy. For all sorts of reasons. So we are not going anywhere near that. We're doing the best we can to control the spread of a respiratory virus whilst operating the Sheffield economy as best we possibly can. And there are some very, very difficult choices. There are no risk-free or easy options ahead of us here, and it will be a really difficult and quite long autumn and winter. You'll now want me to get my crystal ball out and predict how difficult, and I can't. I genuinely can't, but it will be a very difficult autumn and winter. So if I shut up there, and then I'm all yours, and you can go wherever you want. I'll do my very best to be to get to all your questions. I think this is the point I hand over to Emma, who manages me. Emma.
I just start with my screen, so I will scroll across, but I can see Chris Kiddy, and then we'll do Peter. Okay.
Yes, Greg, I think you said there that your sense is that level 3 or tier 3 will come. You think it's inevitable that Sheffield will go to tier 3? Why, and if so, when?
Don't know when. It's clear government are pushing all the northern authorities in that space. The communications we've had are pretty clear. Don't know when. Genuinely don't know when. I think these things are moving in spaces of days and weeks, not months. So if it happens, it's going to be weeks away at most. Why? Because even if you take the student population out of the equation, because by and large, notwithstanding the spectre of long COVID, which is affecting students and older working age adults, some quite severely, most of them are pretty well, actually. There will be seeding of infection from the student population into the indigenous or the normal Sheffield population, no doubt about that. But even if you take the student population out completely, our underlying infection rates are still in the order of 150, 160, and are still going up. And that's the same picture across the most of the north, actually. And the rest of the country will catch up with us. So I think it's only a matter of when, not if, but it's impossible to predict when, to be honest. The job for all of us is to make sure the economic support package is as robust as it possibly can be. And there are uncertainties on all sides of the equation. I don't think government have a certainty on what the impact will and won't be of the shifting from level 2 to level 1 to level 2, level 2 to level 3.
I know you're a public health expert, but from the economic point of view, would you rather be in tier 3? You'd get more compensation for businesses and so on.
Possibly. Couldn't call it one way or the other, to be honest. Yes, you would get more. There would be more compensation. But one thing that's really, really clear is that the compensation applies to, is one, not good enough. I think lots of people have commented on that. They have far more competency than me to comment on such matters. So the furlough scheme, not quite sure what happens to it at the end of October. And it still doesn't cover all of someone's wages anyway. And if someone's hours are reduced, then you're paying less of reduced hours. It becomes quite difficult to live on. And secondly, the economic support package applies to the businesses directly, not the long supply chain that might go with the business. So if a pub employs 15 people, what about all of the, I'm guessing, 30 or 40 people in the supply chain? I don't think the economic support package applies to those. So there are some uncertainties as to whether in totality the economic support package is better in tier 3 or level 3 or very high risk. But again, they're areas that are genuinely beyond my area of competency. I'm moderately good at infectious disease epidemiology, but not so good at economics. So others are working on that one. But there are uncertainties, and it's absolutely impossible to quantify, genuinely impossible to quantify.
Thank you.
Okay, next one is Peter.
Yeah, so Greg, why is it much worse in the north? What are we doing wrong here?
Who knows? And my sense is this: London was affected significantly very early on. That was clear, and had a bigger outbreak very early on. Arguably, there are more people with antibodies in London. Whether or not antibodies confers long-term immunity is anybody's guess. We don't know that. So London had a bigger, earlier outbreak, and the curve came down in London before the curve came down in the north of England. The lockdown was released nationally on the June the something, I should know, but I can't remember. But a time when there was a higher residual infection rate in the north of England, therefore more opportunity to seed more infections, therefore quicker and faster takeoff in the north of England than in the south of England, and the more densely populated, the densely populated northern cities, with the exception of London, obviously, which is a ginormous densely populated city. And arguably, but I've not seen the data on this, I've heard people speculate on this, per capita, more people in the north we're in sort of socioeconomic deciles 1, 2, 3 that genuinely have to do face-to-face work, whether it's in the care sector, the retail sector, the hospitality sector, or other sector, than in other parts of the economy. All of those things together are what people are thinking is the reason for the higher, faster takeoff in the north this time around. The genuine answer is these are questions that epidemiologists are going to pick over for decades to come. But that's the current working theory, which is kind of plausible, but we don't genuinely know.
I know you can't answer the minutiae of every email that we get in our inbox, of which there are many. But just here's an example of somebody who's emailed from Chesterfield. So I'm in a tier 1 area, Chesterfield. I want to come to shop at Meadowhall, tier 2. Is that okay? And can I meet a friend in Meadowhall and have a coffee? Because Meadowhall's indoors, isn't it?
So if I'm in a tier, yes, I think that's broadly okay. But I'd have to read the detailed guidance. You would expect me to know all of the guidance, day in, day out, and I can't. But yeah, yes, that sounds like it works to me.
And pub landlords have been talking to us, saying that, what's the point in opening if you can't meet friends and other members of your family in the pub? It's just a case that it's perhaps better for them to be in tier 3 rather than tier 2.
It might well be. I mean, it's a national set of rules. The purpose of the rules is to give commonality and consistency, because we moved from a space a couple of weeks ago where there was one set of rules in Greater Manchester, another slightly different set in West Yorkshire, another set again in North East. So the idea is to move to something that's consistent across the whole of the country. I think that's a good thing to do. But yeah, I think that the landlords that you've been talking to have a point, to be honest. But only they can make a judgment on how to run their business within the rules that they've got, and I can't make that judgment for them. Nor are they my rules.
Right. Thank you very much.
Thank you, Adam.
Okay. Thank you very much. 2 questions. First one is, given what Boris Johnson said yesterday about being hopeful of a vaccine, but not taking it for granted, have we any idea what sort of exit strategy we can have if there's no vaccine in the foreseeable future? And then my other question is, what can we do locally? Because I've been reading through the council briefing, which I think is very comprehensive as to what being high priority means. But can we do something? It is still very wordy, and it's something, although I think well written. I did spend years working from NCAP, and actually we need to get these messages really, really clear, because if you're getting the question and the answer in ways, I will tell you now, if you are going to get people to cooperate and do this voluntarily, we have to be absolutely crystal clear, and they've got to be able to read it in 30 seconds. And even then, that's pushing it a bit. So.
In reverse order, yes, I agree. Work to be done, always work to be done in that space. On the point of what can we do, the basic, sorry to bore everyone, but I come back to the basics again and again and again and again. Wash your hands, keep your distance, wear a face covering, limit your social contacts. And I've said that to many reporters in lots of contexts, but they do make a difference. You then say, how do you know? Look at what's happened to flu in the Southern Hemisphere in the winter just gone. Flu hospitalizations have fallen off a cliff. because everyone's washing their hands, wearing a face mask, keeping the distance, and the things that protect us from flu, and notwithstanding the vaccine point, and I'll come on to vaccines in a minute, are the same things that protect us from this respiratory virus. Second reason why is every week Public Health England send me the gastrointestinal epidemiology charts, the norovirus, the DNV, the this, that, and the other, which are really impacted on by washing your hands. Norovirus infections have gone off. They've just gone off a cliff from lockdown onward. Well, actually, no, from January onwards when we started ramping up that messages, and they've remained low. There are some caveats to that, but those basics do make a difference. And the other stuff is that if you've got a symptom of even mild, get a test, and if you're asked to isolate. So those kinds of things, I'll just come back to them time and time again. There may or may not be a vaccine in the foreseeable future. We can live in hope. If I had to call it, I would reckon there would be a vaccine February, March-ish next year. It will take us at least a year. We're going to try and vaccinate most of the population, as far as I can tell. That will be a ginormous logistical exercise, and we'll get through it as fast as is humanly possible, but it will be a long time before we have a vaccine. That is making an assumption as to how effective the vaccine is, i.e. how much protection it gives us, and how long and how robust the vaccine-induced response is. And no one knows. We genuinely don't know that. These are questions that scientists are pondering over. Scientists considerably cleverer than I am. So I think the basics will still continue to matter for some considerable time to come. And people are beginning to talk about adaptation. How do we adapt the systems and processes that we've got in the city, the way that we run our city, the way that we run the built environment to reduce touch points, flash points, busyness, the way that we run our services to reduce some of this stuff. I think we'll get into that space. I will come back time and time again to a robust contact tracing system. There is a robust contact tracing system. It's called NHS Test and Trace. To its credit, it works. It works on a giant scale, but it doesn't work well enough and it doesn't work fast enough. So we do need to make improvements there. And of note, lots of talk from government over the last few days is around localizing testing and tracing. Great, thank you. It needs to be resourced. And most these BH, including me, have been asking for it for about the last 5 months. So I look forward to the day when we can truly localize contact tracing at the scale that we need to. But until then, we're stuck with the basics of kind of respiratory protection, I might call it.
Look at the next one, Liz Roberts.
Hiya. It's sort of along the lines of what Peter alluded to, really, but I just wondered whether legislatively you know whether these rules apply specifically to people or place or both. Because being on a border with an area that's in a different tier, if, for instance, I'm in Chesterfield, hi everyone in tier 2, but what effect does that have on people coming across into North Derbyshire? Do they then do those rules apply in restaurants that are and bars that are still open and allowing people to mix in there to mix up to 6 inside? Likewise, if I go into Sheffield, like what advice will the City Council be giving pubs, business owners, restaurant owners in Sheffield City Council, who it appears as though the government wants the onus to be on business owner? You've got to check to make sure people aren't mixing. But if I'm from Chesterfield, can I just go, it doesn't count for me? So, how does it operate? Is it people, place, or both?
Probably both, Liz, to be honest. My sense is the initial focus will be on people, but then they'll invariably be on place. Somebody asked me this morning, I live in Halfway, can I go to the pub? If we're put into level 3, can I then go to the pub in Eckington, please, which is in North Derbyshire? So I looked, and basically, no is the short answer. And the specifically what it says in the very, very high categories, people should, and hence I'm thinking people, not place, people should try and avoid travelling outside a very high alert level, only other than for things like work, education, voluntary, charitable or youth services. So by implication, the person who lived in Halfway can't go to the pub in Eckington. So I'm thinking it does apply certainly to people, because the talk in the guidance that will get turned into law is about people, but invariably it will turn into place. Notwithstanding the fact that this will turn into law, I certainly know, because I get the feeds from the guys that do the visits to the hospitality venues. They consistently say that other than one or two exceptions, the hospitality sector in Sheffield and everywhere else, I don't think Sheffield's special here, have really worked hard to make their venues COVID safe. So I do think I'm being careful about how we approach this, because the last thing that anyone wants is further economic damage. But to answer your question directly, Liz, I think they apply to people and place. And if you're in high risk, a very high risk category, you can't go to a pub in another part of the world that's not in a high risk category. And I suspect that cuts vice versa as well.
But at the moment, given that we're only in high risk, as opposed to very high risk, which looks as though there's some advice on travel, like you say, across borders,
yeah,
isn't necessarily, it looks like it's advisory and not necessarily. And
yeah, no, of course, it's advisory and it's guidance. At which point I come back to consensus and consent. If we all have giant social circles and we all choose to ignore the guidance, well, the rates of infection just continue to go up and up and up and up. So there is a bit of enlightened self-interest in this for all of us, actually. But it's guidance. We can't enforce. The police will tell us very clearly they can't enforce the law in the context of guidance.
Okay, thanks.
You've got Ben next.
Hi, Greg. Given that we've already seen that the restrictions that are coming into place in South Yorkshire tomorrow have already been placed in a number of. Can you hear me?
I've got a very dodgy line. I can hear every word, every fourth word.
Oh, it's a dodgy line.
No.
You're sounding a bit robotic as well. Can't hear me.
No.
The text. Write your question there.
Sorry, I can't hear you. It's... Bear with. Is that better?
No. Do it in chat, Ben, and I'll try and answer it in chat. Emma, do another question whilst Ben types.
Yeah, can we just go for a next one just while you're typing that? Is that all right? Baylor?
Yeah, fine.
Yeah. Hi there, Greg. Can you hear me?
Yeah, good. Loud and clear.
All right. You mentioned that some hospitals in South Yorkshire are getting busier, and it's going to be a very difficult time for the winter. Having said that, so in terms of the hospitals, how prepared is the NHS? And do you think in terms of that, they will be able to cope when the winter comes? Because we know that the winter, it's always busy. That's my first question. And the second one, you mentioned that the government exit strategy plan is not properly clear. So some of the councils or local authorities will be given some powers. So is there any plan B? Let's say if the central government's exit strategy plan is not clear, but there is a plan B from like Sheffield City Council or the local authorities. Is there anything that you've got as a plan for the public in Sheffield?
So in reverse order, I don't have secrets up my sleeve. You know what I know. The plan is the plan. I come back to it time and time again, which is the outbreak management plan. I think we published months ago actually. The basics haven't changed much. The plan is prevention, which our environmental health officers do day in, day out. They've visited thousands of premises. They're about 10 times busier than they normally are. The efforts that schools, universities, businesses, pretty much every sector, care homes, I'll have forgotten somebody important, putting on preventing infection in the first place and keeping places COVID secure is theme one. Theme two is robust contact testing and contact tracing. As I say, it's a little bit beyond my control, but we're working with government. Theme 3 is outbreak management when it happens. So we've got pretty robust arrangements in to manage outbreaks. They don't always work and they're never quite in control. Early on, we had some significant outbreaks in workplaces, in places of employment. They were managed quite well. The thing of the moment is universities, ginormous outbreak in universities, and then comms, marketing, messaging, media, which Emma is and Mark McAdam, who's online, have done a huge amount on with, and our approach is to clarify confusion. So they're the basics of the plan. We're continuing to intensify our efforts, but the basics, they're not going to change. The basics of that plan aren't going to change. They're broadly the right things that we need to do. We'll continue to intensify, but at the moment I have no secrets up my sleeve, sadly. I wish I did. If we go further up the escalation into tier 3, that does come with resources. I understand from Sheffield, sorry, wrong region, Liverpool City region, it's in the order of £8 per head. So that's a non-trivial sum of money. And we'll need to work out how we invest that, but they'll be invested in interventions that we've already set out around supporting vulnerable individuals, localizing contact tracing, and the localizing our efforts around prevention. We'll continue to ride the wave. This is a global pandemic. It's affecting everywhere. It's affecting some places worse than others. At the moment, the business end of this in this country is in Northern England, but everywhere else will catch up, but we'll continue to ride the wave. On the NHS question, planning for winter, every winter the NHS puts huge effort into planning for winter. This year will be more intense effort on planning for winter. Huge effort on flu vaccination, and that's happening now. I'm told it's going quite well. Certainly the GPs I speak to tell me that they've done most of their flu vaccines. I don't think that will be the same across the whole of the city, but certainly the ones I've spoken to recently, they said they've vaccinated most of those who they are needing to get to. We've extended the flu vaccination program to cover younger adults down to age 50, I think it is, and we'll continue to do that. The Nightingale Hospitals have been stood up. They're not open, but they've been asked to be ready to open with seven days notice. I'm pretty sure the NHS are trying to avoid wholesale cancellation of elective work because that comes with consequences, as we've seen already earlier on in wave 1, and I've not seen any plans to cancel elective work. I don't think that could ever be completely taken off the table. Non-elective work, aka emergency admissions, always takes precedence over elective work, but at the moment the NHS, as far as I'm concerned and can see, is in a pretty good state in terms of its planning and preparedness for winter. But it will be long and difficult, and it's impossible to, I can say that now, but next week, 3 weeks time, 4 weeks time, I might be saying different things. But as we stand now, the NHS is in a pretty good state of preparedness.
Thank you.
So that's like, shall I get to Ben's question?
Yes, Ben put his question in the chat, but has he got better now?
Has he gone? Ben, are you still there?
He was trying to get back.
I'll wait for him to come back in because I'll wait for him
back in.
Right, I'll wait for him to be able to hear. Ben, hi. Welcome back. So the question was, do you think lockdown was eased too early for the North? It was eased. It was the lockdown was eased nationally. It was a national policy decision. I think it would have been in hindsight, yes, possibly. No definitive answer one way or the other, and I'm deliberately not trying to sit on the fence here. It would have been operationally difficult, given the circumstances of the time, to differentially release lockdown in some parts of the North later than some parts of the South. I can just imagine the problems that would have caused for people that live in the North. 3 or 4 months down the line, we can all look back in hindsight and say it was probably too early, but the decision at the time was a national decision, and it was probably the right decision to be made with the information that was available at that time. Hindsight will tell us a different story, and clearly the analysis will probably tell us a different story in the future. But at that time, it was the decision that was made, and it was probably the right one, given the availability of information that was on the ground at the time and what was there at the time.
Anything else? I think there was there?
Okay, thank you.
Okay. Next on the list, got Michaela.
Yes, hello. I'm just inquiring, I really would like to, have you got any broken down figures about the more rural areas of your patch? I mean, that obviously the more rural areas have less cases, and I mean, it's a difficult balance to try and sort of not penalise those areas that have very few compared to Sheffield City, which has obviously got more.
Yes, I do. I don't have them to hand, but as a rule, the infection rate is pretty equitable across the whole of the city at the moment. We saw that in the first wave, I think in time, because of population density, because of the type of people that live in rural areas and their work patterns, we'll see a lower infection rate. But at the moment, it's about fairly even across the city. I don't have the data to hand, I'm afraid, though.
But compared to rural areas, are you sort of meaning the city as in the whole region, or are you meaning the rural areas as well?
The rural areas of the city, yes. So look at it ward by ward, and it's not completely even, but there's infection across the whole of the whole of the city, and it's not unequally spread. I think if we roll it forward another month or two, and it probably will be unequally spread in a sort of an east-west type of pattern. But at the moment, it's reasonably equal.
Okay, thank you. That's it really from me. Thanks.
Okay. Our next journalist inquiry is Steve Jones. But I think we did miss something potentially off for Ben. But I'll have a look and perhaps catch up with you afterwards. Did you get everything you needed, Ben?
Switch them again.
It was Ben's first question.
Yeah, sorry, I had to off and come back on to.
I found it, Ben. The questions were the restriction we're getting in Sheffield in place on a number of other parts of the. A number of other parts of the country are already in lockdown. COVID rates have continued to rise in those places. How confident are we that they'll bring rates down in Sheffield? Mixed confidence, to be honest. Everyone wants silver bullets, and they don't exist. For me, the question is about rate of rise rather than bringing rates down. And the point of restrictions on social mixing is to to slow the rate of growth, eventually to dull the rate of growth, but to bring R naught closer to 1. Currently, if I had to guess it, and no, I won't guess it, but because you'll all quote me and it's a guess, but it's probably well above 1 at the moment, and the closer it is to 1, then the infection dies out of its own course. So the point of the restrictions is to bring R naught closer to 1. Some signs I've seen from some analysis that was done in northeast England, where they have had restrictions that do involve the hospitality sector and household mixing for the past month or so, the rate of growth has flattened significantly. However, there was a paper published in the British Medical Journal last week that said, and I think that what led to your question, rates have continued to rise. And yeah, that is the case. Rates are rising across Northern England. And for us in Sheffield, our university population has driven it. But even if you take the university population out, rates are continuing to rise. My aim is to get R naught close to 0, and then that flattens off the rate of growth completely. And restrictions will help that, but aren't the magic bullet. It can come back time and time again to the behaviour and the choices that 580,000 people make in their own homes. That will be the thing that really, really makes a difference.
Okay, I think everyone's got what they needed there. I think Jane's got to go. Has Jane already left? Yeah, I think Jane had to go. She's posted her question, so I think we can perhaps answer that afterwards. Michaela, sorry, love, we're coming back to you now. Is that all right? You don't need to. You sure? Sorry, you were waving. Okay. So we've got Steve next. Steve Jones.
Hi, Greg. A few questions. first of all, given you said that it's a matter of when, not if, we're going to go into tier 3 potentially, what are you on the lookout for? Is it infection rate continue to rise, or hospitalizations, or are there other factors?
Go on. Do the lot, and then I'll pick them up.
No, it's obviously there's been a slight decline in the infection rate in the city in the last few days. Is that just negligible, or is it an encouraging sign, given what you said to Ben just a moment ago? And finally, sorry, one more question from a pub owner. I run a pub, and my main question is, if I challenge someone about sitting here with another household and their reply is they live together, who would face the penalty if they got an inspection and it turned out they're not from the same house?
So in reverse order, I genuinely don't know. Again, you expect I know all of this stuff, and I don't. But I'll turn that into one of the answers to the frequently asked questions. It's the first time it's cropped up, but invariably it will crop up frequently. So I genuinely don't know the answer to that one. My sense is it would be the pub, because it's the premises upon which that happens. And it would be, this is my off-the-cuff answer rather than my completely thought-through answer. It would be the owner of the premises that would face the consequences. And if that would be enforced by either environmental health or the licensing team, if it was someone's private premises, it becomes a police matter to enforce. I mean, we are looking at how we take the right approach to enforcement. I think the bottom line is, I don't think it's right or appropriate that we send the police in to kick doors down for minor incursions of the law. The law will be enforced, no doubt about that, but just getting the line to take here, because I come back time and time again, social consensus and consent is the only way we'll manage this. And the private choices that 580,000 people make, that's the way that we'll resolve it, rather than having the police on every street corner. It's just, that's just a non-starter. But to the specific answer to the specific question is, I think it would be the owner of the businesses that would be kind of the person that would get enforcement action in that circumstance. The decline, yes, there has been a slight tailing off. I'm hearing that is a tailing off in the 15 to 25-year-old cohort, aka students, not exclusively student population, but largely students, and that's consistent with what I've observed, or what I've seen to be observed in Scottish universities. I think it's too early to call definitively one way or the other. We'll all watch it with interest. We'll see what happens. As I say, if you take the student population or the student age population out of the picture, the underlying rate is still upwards, but it's all a bit skewed by the 60,000 students that we've got at the moment. But I think there has been a decline. It's too early to definitively call one way or the other, and I'm watching with interest. And then in terms of the threshold for escalation, I've not seen a definitive written threshold for escalation. My sense is it will be made up of the following: 7-day rolling incidents per 100,000, test positivity, and last time I checked, test positivity in Sheffield was about 14%. So of 100 people with symptoms that then go and get a test, 14 of them test positive. A month and a half ago, that was 1%. So it's gone up. Well, I think it's 1.5.
Is there a threshold? Obviously, you said it's 14.
No, I've not seen a published threshold. The thing that made the difference for Liverpool City region was hospital activity. That was the thing that really tipped it over the edge in Liverpool City region, which we're not yet seeing that at the same scale here. But the curve is pretty simple. And the other thing which concerns me greatly, and I picked that sort of right at the very start, is age-specific incidents in over 65s. That's the group that are most likely to have severe illness that ends in hospital admission. Not to say that there are younger people will be completely immune, they're not. But it's the over 65 7-day incidents, which is the thing. It is rising. There's no doubt about the fact it's rising. About 160, 170, 100,000. I'd have to relook at the chart in that order, and it's rising. It's rising across South Yorkshire actually. So those are the worry signs. But to answer your question specifically, I'm fairly certain I've not seen an explicit written threshold for intensification. It purely epidemiologically, it probably makes sense to act sooner rather than later but then there's the whole social and economic harm factor that needs to go into the mix, and it's a very difficult balancing act for government actually, and a lot of uncertainties on all sides of the equation.
Okay.
I think that's everything there. I think Michaela had one more question. She put it in the chat.
Yes, I did. I just wanted to ask about is there a race to get elective surgery through before more COVID patients hit hospitals?
Not to my knowledge, and I wouldn't characterise anything as a race. The NHS is a pretty efficient machine. It does the work it needs to do. I think it will be trying to do the elective work it needs to before winter hits. That happens every year. I don't think I'd want to characterise that as a race. The NHS is doing the elective work it needs to, and it's making prioritisation decisions. The NHS always does that, does so pretty well, in my opinion. Characterising it as a race, I think, would be a bit unfair.
Okay, perhaps race was the wrong word, but a surge, an increase, a severe increase in the amount that they're trying to get through.
I genuinely don't know. I don't get to see. I can find out, but I generally don't get to see and don't routinely monitor the rate of elective surgery that the NHS does. It would be a question for NHS commissioners and/or providers, and I could find out, but it's just not something that crosses my desk on a daily basis or a weekly basis.